Dr. Griffith, attendance
Uh-huh.
is looking good if you'd like to get started.
Okay. So hi, my name is Chris Griffith. I'm one of the clinical geneticists at USF, and I'm here today to introduce our genetic counselors who will be discussing the role of genetic counselors in medicine. So we have 4 genetic counselors today. We're missing one name from our slide. Brittany Sears is coming to speak to you from our oncology department, TGH. And then we have 3 other genetic counselors who work with us in pediatric genetics, Melissa Racobaldo, Deanna Almanza, and Meghan Kelley. They've all been with us for a number of years now and are all excellent. Genetic counselors play a very important role in what we do in genetics. They have a lot of times the most interaction with the family before and after the visit, and also help coordinate quite a bit of what we do. So it's something I think that other specialties outside of genetics don't necessarily understand the complete role that genetic counselors play. And so they're hopefully going today to kind of fill you in some of that and give you an idea of how interactive they are with patients and how valuable they are to our team. So with that, I'll let them start.
All right, thank you so much for that introduction, Dr. Griffith. Like you said, my name's Megan. I'm one of the PEDS genetic counselors, and so my colleagues Melissa and Deanna and I will start off by talking about the role of genetic counselors in medicine. And we're so grateful to have this opportunity to talk to you all today. We know that oftentimes healthcare professionals don't have a chance to train with genetic counselors or work with them, so we're hoping to clear up any questions you might have about our role in medicine. So we don't have any conflicts of interest to disclose at this time. And our objectives for this presentation are to define the role of genetic counselors in medicine, discuss patient cases where genetic counselors improved outcomes, and identify cases and indications that would benefit from a genetic counselor. Next slide. Yep. And so oftentimes we get asked, what is a genetic counselor? And I think any genetic counselor will tell you that we kind of have a long-winded response prepared. And actually, the National Society of Genetic Counselors created a task force to try and help create a more succinct response to that question. So I will read that for you here. Genetic counselors help people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. The process of genetic counseling integrates the following: interpretation of family and medical histories to assess the chance of disease occurrence or recurrence, education about inheritance, testing, management, prevention, resources, and research, counseling to promote informed choices and adaptation to the risk or condition. Next slide. So to become a genetic counselor, an individual has to complete a master's program in genetic counseling. These programs have to be approved and certified by the American Board of Genetic Counselors, or ABGC. Currently, there's about 50 to 55 programs in the US, and I think just to say, when I applied in 2018, 2019, there were only 30, so the profession is growing. And USF has Florida's first and only genetic counseling program. Once individuals complete their master's program, they can sit for the board exam that's administered by the ABGC. And once they pass that, they can renew that board certification every 5 years through continued education credits. Some states do have licensure for genetic counselors and some states don't. In Florida, they approved a licensure for our profession in 2021. And as it stands right now, that licensure will be renewed every 2 years. Okay.
This is one of the graphics from the NSGC, or National Society of Genetic Counselors, Professional Status Survey. So this is a survey that goes out to all practicing genetic counselors annually to be able to get a feel on the workforce and where it stands currently. And one of the things that I wanted to highlight were just the different work environments for genetic counselors. So traditionally, and through our training, through our master's program, we do clinical rotations, and they're predominantly in cancer, prenatal, and pediatric genetics. And you can see that those are still the majority of those specialty areas that genetic counselors practice in. But we have expanded our specialty areas into over 20 different types. So outside of those kind of 3 main practice areas that we work in. And even here within our team, you'll hear a little bit more about how we do pediatrics, general, adult, metabolic, and cardiology disease. So That's probably part of that 60% of individuals who report having 2 or more areas of practice that they specialize in. And it is really exciting to be able to see this advancement. So individuals have gotten into neurogenetics, genetic counseling, and ophthalmology genetic counseling. So a lot of different opportunities for genetic counselors now. And we work in a variety of settings like universities, hospitals, laboratories, nonprofits, and government. And you'd be hard pressed to find any genetic counselor that would say that they have one and only one role within their job. So direct patient care is the large majority of individuals in the field, but there is overlap. So individuals do direct patient care and education and teaching and research. So it's kind of like that primary role and these other, minor specialty roles too. Next slide. So the growth of the profession, this chart is showing the growth of the genetic counselor profession between 21 and 2031. So over 10 years, it's expected that the field will grow by about 18%. And when compared to other healthcare practitioners and tech occupations, that leaves them at about 12%. And one of the things to kind of highlight about this 18% growth is what that really means is only about 500 genetic counselors that will be added to the current practicing workforce. So that's really not a lot. And some of the limitations with being able to add more genetic counselors into the workforce is the limitation of being able to have those training programs and those clinical rotation sites, just as there aren't as many currently practicing. And as Meghan had mentioned, in the state of Florida, the USF program is the only practicing or only current program in the state of Florida that trains genetic counselors. And as it stands now, they're only accepting 5 in each program. So 5 students that they're training currently. So there really are limitations to training and being able to kind of generate a lot of individuals in the genetic counseling workforce. And then this will kind of run into the next slide where we talk about barriers to receiving genetic counseling in healthcare. So in 2021, this article that was written talks about different barriers and facilitators to genetic service delivery models. So again, the number of practicing genetic counselors is a huge limiting factor to being able to serve individuals who would benefit from the service of having genetic counselors. That also kind of contributes to the wait time. So even with our team here and being able to see our geneticists and genetic counselors, there's a pretty long wait time to get in to see us. So sometimes that results in delivery of service by non-genetics providers that we'll talk about a little bit later too. And then as Meghan had mentioned, the licensure is a great step towards being able to increase reimbursement and recognition from different payers that genetic counselors are healthcare professionals that should be able to serve and provide services to our patients. Some of the facilitators that they mentioned are telehealth, group genetic counseling, provider-to-provider education, partnership models, training, expanding genetic provider types, embedding genetic counselors in clinical settings. So with all of these facilitators, kind of the things that we like to highlight is what seems to work the best and what's kind of known to work the best to be able to get genetic counselors involved is having a sort of interdisciplinary workflow that you have. So you have the genetic counselor who is the expert in being able to communicate with the families and talk about genetic testing and figure out the best labs to work with when ordering genetic testing. And then you have the other specialists who really help with that clinical portion of it. So if it's neurology genetic testing, then the neurologist helps with piecing together the clinical information for the families too. So really that collaborative effort is what gives our patients the best outcome in their healthcare. And then next. So this article, this one is from 2019, but this is highlighting different adverse events in genetic testing. It's the 4th of its case series. And this one reviews 25 cases total. And we're not going to go through all 25 cases, but it talks about different specialty areas where a genetic counselor wasn't involved, whether it was medical grade or direct to consumer genetic testing. And the patients had experienced some adverse events by not having a genetic counselor involved. So the next slide does lay out and categorize the different types of events that occurred. And one of the most common causes of adverse events was that the wrong genetic testing was ordered. And then as you kind of read down, you could see there's different adverse events, whether the testing wasn't accurately explained to the patient or it was just a little confusing what they had, or they had to have a reinterpretation of the results. And then sometimes the testing labs don't get the report right. So sometimes there are errors in the results that we get from the lab. So being able to have the genetic counselor's eyes is an added bonus to be able to see, the effects of the testing for the individual patients. And then the next slide kind of talks about the overarching or 4 main categories that I think about when I think about possible harm to patients for not having a genetic counselor involved in their genetic testing and genetics process. So this could lead to delayed time to diagnosis, a misuse of money and resources, misdiagnosis or mismanagement, and unexpected results that can come up. So the case series that was mentioned in the previous slide does give different case examples of these different types of categories for possible harm, but specifically for delayed time to diagnosis, they talk about an individual who has a personal history of cancer. So the provider ordered BRCA1 and 2 testing, came back negative, and then was referred to genetic counseling. And when the genetic counselor was able to do a deep dive into family history and gather information about other family members, autism diagnoses, different types of cancers or malignancies, they realized that the patient actually met criteria for Cowden syndrome and was able to proceed with genetic testing. And that was the correct diagnosis for the patient. So it took a little bit of time for them to receive that correct diagnosis to help with management and counseling for the patient. And then that one kind of overlaps too with just the money and resources. So sometimes this genetic testing, if insurance doesn't approve it, can cost several hundreds or thousands of dollars to the families. So it's not uncommon for us to have families that come to us where they have had genetic testing that was ordered by a different provider, and they spent out of pocket, $1,500 or $2,000 for the testing, and it wasn't the most effective or most efficient testing or best testing for the patient. There's different types of genetic variants that can occur, or different types of genetic testing or genetic variants that can cause certain genetic disorders that not every genetic testing evaluates. So not every genetic test is created equal. For example, we see adults who have spinocerebellar ataxia, and most often that's caused by trinucleotide repeat testing. So if someone were to order just an ataxia gene panel that does sequencing, we would be missing out on all of that information for trinucleotide repeat expansion disorders. And then misdiagnosis or mismanagement. This goes back to another cancer case that was presented in that case series. But an individual had a family history of cancer on both sides, and only one side of their family history was investigated, and they were found to have a hereditary cancer syndrome consistent with that family history. But when a counselor got involved, again, on the back end, they were able to investigate that other side of the family history. And unfortunately, this individual was found to have 2 different types of hereditary cancer syndromes, but now they were able to have the correct surveillance and management for them to catch something early or to prevent certain cancers from occurring. And then unexpected results is another thing that we really talk about when we're doing pre-test counseling for our patients. So obviously we want to see everyone before they get genetic testing to let them know about possible results that could come. And it has happened in the past where we've had families or we've had patients that the genetic testing can tell us about the biological relationship or inaccurately reported biological relationship of parents. So sometimes that means non-paternity or consanguinity. And when we go through that pre-test counseling for the families, we give them the opportunity, if there is a suspicion for that, to communicate with us to say, how can we best move forward to protect the family unit and to protect all the individuals that are going to be involved if it is something that could cause a lot of chaos or a lot of harm to the family. And then next slide. So this slide I wasn't really going to go through too much, but this is just, there's a lot of articles out there and a lot of information out there. So these 2 articles were just talking about medical management adherence as an outcome of genetic counseling, and then the impact and positive impact of receiving a diagnosis when it comes from a genetic counselor. So just 2 big themes that we see where genetic counselors enhance receiving a diagnosis or even a non-diagnosis, a diagnostic odyssey, having a genetic counselor with them, and then just being more likely to follow medical management guidelines and recommendations with a genetic counselor involved.
And so then I just wanted to introduce and give you an example of how the different roles that we have in our clinic here at USF. So of course, we're involved in our clinics. We staff clinics with our 5 providers. We have 3 geneticists and 2 nurse practitioners. In our general genetics clinic, we see mostly pediatric patients, a handful of adult patients for certain indications. And really our role here is to help these patients along their diagnostic odyssey to see if there is a genetic cause for their symptoms. Our metabolic clinics are staffed by our metabolic team, including our metabolic geneticist, Dr. Sanchez. She has a metabolic nurse practitioner, Cassie, and we have a metabolic nurse whose name is also Deanna. We have 2 metabolic dietitians and a social worker who's typically always available. And then we jump in for these patients at the time of diagnosis, and then at the point in their life when they have maybe some decisions to make, such as family planning or something like that, if they want more genetic testing, those types of things. We do have a cardiogenetics clinic that we staff with Dr. Griffith and a cardiologist, Dr. McDonald. We see adults for hereditary cardiomyopathies and arrhythmias in that clinic. And then we have a genetic counseling clinic where we take the main role, the lead role there. We've been seeing a lot of adult patients in that clinic for neuro disorders, so ataxias and those types of things, where they need counseling on test results that they may already have. The USF is also a newborn screen referral center, so our newborn screen coordinators receive normal newborn screen referrals. Our role for those patients is to counsel them on those initial results. Sometimes we help coordinate additional genetic testing or confirmatory testing. We really get involved on those disorders where genetic testing is included in the screening done by the state. That includes X-linked adrenoleukodystrophy, Pompe disease, spinal muscular atrophy, mucopolysaccharidosis type 1 and type 2, and then of course cystic fibrosis. We can help test parents and test maybe siblings who are older and may not have had the benefit of having these disorders on their newborn screen. We also participate in education and training, of course, doing lectures, being an instructor for the GC program, and then being clinical supervisors while those students are doing their clinical rotations. Okay, in the clinic, we are involved before clinic doing chart reviews, literature reviews, and gathering testing options for those patients. While in clinic, we do medical history intake that's targeted for our purposes. We always do a family history. We draw a 3-generation pedigree. We counsel before testing, as Melissa already kind of spoke about, talk about possible results, the benefits and limitations of genetic testing, risks such as non-paternity consanguinity that may come up. Post-test counseling is reviewing those results with the patient and their family to talk about what that means for the patient and for family members. And then, of course, outside of the clinic, but related to clinic, is ordering the testing, working with insurance to get testing covered, and then communicating with families about their results or just answering any questions that they may have. And then I am going to pass that over to Melissa again to talk about our patient cases.
Okay. So kind of to get into our patient cases, I think everyone loves case presentations because it highlights a little bit easier than just the lecturing piece of things when you actually put a case to or a scenario to, a specific outcome. And the first case that I have is talking about neurofibromatosis type 1 or NF1. And I chose this case because I know NF1 is something that we probably all have learned about and discussed. It's one of the more common genetic conditions. So the prevalence is about 1 in 3,000. And this chart specifically is from Gene Reviews. So if you haven't used Gene Reviews before, this is our favorite website to use, or at least a good starting point to find out all the information you could ever want to find about certain genetic conditions that they have. And then this chart specifically is just giving you the features of NF1, the percentage of individuals who have those described features, the typical age of onset that you would see in different comments about whether they increase over time and just what throughout the lifespan those features might look like. So as you can imagine, you see the cafe au laits. Pretty much everyone with NF1 is going to have cafe au laits, and then the neurofibromas are one of the more common ones, as well as the Lish nodules. On the next slide, we can see its suggestive findings of NF1. So another reason I selected NF1 is because you can have a clinical diagnosis. So if an individual has 2 or more of these features described in suggestive findings, they have a clinical diagnosis of NF1. So you could possibly be wondering what's the utility of doing genetic testing if someone can just have a clinical diagnosis. Sometimes we have, especially in the pediatric world, individuals who come to us that only have cafe au laits and they don't have a second clinical diagnosis or clinical criteria met yet in their life, and doing genetic testing will get them that second hit for being able to have that clinical diagnosis, that germline pathogenic variant in the NF1 gene. And then sometimes there's descriptions of different genotype phenotype correlations in NF1. So being able to provide a little bit more information to the families to say, individuals with this specific type of genetic variant in NF1 have had this type of prognosis or have had these features. We wouldn't necessarily change surveillance or management for individuals based on their specific genetic variant. We would still kind of go through the screening recommendations for them, but just to be able to give the parents a little bit more anticipatory guidance to be able to say, you know, it's more or less expected to have these certain features. Still with NF1, we do see a great variability within families about presentation of features. So individuals in the same family can have really variable presentation in the symptoms that they might see. So just because someone has cafe au laits and neurofibromas in the family doesn't mean that if they were to have children, that that's the only symptoms that they would also have. And when we do talk about NF1 with families, we know that about 50% of the time, if we diagnose someone, an individual with NF1, one of their parents is going to have the clinical diagnosis too. And when we do genetic testing, the detection rate of finding a pathogenic variant in NF1 is about 95%. So of individuals who meet clinical diagnostic criteria for NF1, about 95% of them will have a pathogenic variant that's identified on genetic testing. The next slide is going into my specific case that I wanted to present, and it's a 36-year-old that we saw within the past few months. And she was known to our clinic. She hadn't been seen in several years, but she had a diagnosis as a child. She had presented with cafe au laits and then neurofibromas. And over her life, she'd had some neurofibromas removed that were causing pain. At the visit, she endorsed some lower back pain. And then she recently identified a lump on her breast and was proceeding with mammograms. So she was a little bit more in tune with her breast health, given her concern or diagnosis of NF1. And then an old clinic note had mentioned that her father had Lish nodules. So she was getting back into us after several years of not returning to clinic, which is fine. She was getting management elsewhere, but she had some questions about family planning. She just wanted to know a little bit more about, risks to children. She knew about the 50% or 1 in 2 chance for her children to have NF1. And also she hadn't had genetic testing up until this point, just because it was expensive and not covered by insurance at the times that she had been coming to see us. Now that we have more genetic testing labs available to us, it's driven the cost of testing down. That competition has greatly benefited our patients, as well as insurances just being more likely to cover genetic testing, understanding that it really helps with medical management, having genetic testing completed. So when we did her genetic testing, which is screenshotted on the next slide, we did find a pathogenic variant in the NF1 gene. And the labs oftentimes give you a summary of the variant. And one of the things that I wanted to highlight from this specific variant summary was that it's a premature translational stop signal observed in individuals with NF1 and also with NF Noonan syndrome. So while we have NF Noonan syndrome kind of in the back of our minds as we're counseling patients and talking about NF1, oftentimes we don't have our own specific patients or kids who have clinical features of Noonan syndrome as well. So it's not something that, we really regularly harp on or, talk to these patients about. This individual also didn't have clinical features of Noonan syndrome. But when we think about NF-NS too, and on the next slide, it kind of talks about where we would see that in the clinical features of Noonan syndrome, but about 12% of individuals with NF1 do have NF Noonan syndrome. So they do have clinical features of both NF1 and Noonan syndrome. And the clinical features of Noonan syndrome are just described here, some of the dysmorphic facial features that you might see, and the congenital heart defects. And families with NF-NS can also have individuals who just have NF1. So we talked a little bit about clinical variability, but that can also trickle into as far as having NF Noonan syndrome. And it's caused by pathogenic variants in NF1 only, or sometimes we have families that have both NF1 and PTPN11, which is a gene associated with Noonan syndrome that tracks in the clinical presentation of the family members. But for our specific patient, they included that variant in this NF-NS kind of report in the result because it has been something that has been described. So on the next slide, it shows the specific article where they talk about NF-NS, and it describes the same variant in a family that our patient has. So individual 1-2, that's the father, and then his two children are 2-1 and 2-2. That's the little family history that you see there. And all three of them do have a pathogenic variant, the same one that our patient has. And the father himself has a clinical history and has clinical symptoms for NF1, and he does not have any Noonan syndrome features. His two children, there's some appreciation for the younger child to have different dysmorphic features that could be fitting with Noonan syndrome. He did not have a congenital heart defect, but the oldest child of his, a daughter, she does have a congenital heart defect, and she does have clinical symptoms of Noonan syndrome. So she has a diagnosis of NF Noonan syndrome. So while I mentioned this is something that we talk about for our family, sometimes it's not really real or in their mind until they have this genetic testing result where we can say there has been a family that's been described where they have NF1 and NF-NS in them. So on the next slide, we kind of brainstorm and think about what are the implications for that family member when they're thinking about having their own children. So specifically for our patient, in her family planning options, she knows about risk to offspring for NF1 and that how variable that clinical presentation could be. But we're, a little bit more definitively including this risk now to have a child with NF Noonan syndrome. And while we talk about and introduce some of the options for prenatal diagnostic testing like CVS and amnio or pursuing in vitro fertilization with pre-implantation genetic testing, we introduce our prenatal counselors or preconception counselors through USF MFM. If this is something, this is their plug for referrals if you ever had to refer anyone to them, but to really go through that process with the family. Maybe this is something that completely changes their thoughts on family planning, or, a consideration that they didn't have before. They heard about it and they knew it was a possibility, but to kind of have that concrete genetic testing report to say, it's been described before and it's a possibility for sure. It changes the conversation a little bit. So I just wanted to highlight how, having that genetic testing in addition to the clinical diagnosis could really change thoughts and considerations for our patients that we have.
Okay, so I just wanted to present the second case. So this is a 22-year-old female who I saw with Dr. Griffith. She came to us with the diagnosis of autism. She was diagnosed at age 16. She also had abnormal Parkinsonism and catatonia. She also had a history of developmental delays, dysphagia, a gait abnormality, anxiety, and ADHD. At 19 years old, her parents reported that they noticed a significant decline in her ability to take care of herself and a shift in her personality. She was showing verbal aggression, impulsivity, and poor sleep habits. They were thinking that this possibly was due to starting medication and stopping medication. They had diagnosed her with NMS, so neuroleptic malignant syndrome as well. Just part of our normal workup for an autism diagnosis, we wanted to proceed with a chromosome microarray and Fragile X syndrome testing, but we also wanted to order a whole exome sequencing with mitochondrial DNA to cover single gene causes of autism, movement disorders, and maybe even those psychiatric symptoms and some of that psychosis stuff. So this is just a slide going over the results that we received. And that top right corner, I included just a table reminding you of the different types of results we can get from Fragile X syndrome testing. In her FMR1 gene, she had 31 and then 20 CGG repeats, so firmly in that normal range. She had a normal chromosome microarray. And then in the bottom right corner, we see the results of the whole exome that we ordered with the mitochondrial DNA. So that last bullet point right above the table, you see that their mtDNA results were negative. And then in the table, there's 3 variants that were found on whole exome. That middle row is a variant in KDM5B. You see that in that third column, that KDM5B is associated with a recessive condition, meaning that you need biallelic pathogenic variants in that gene in order to have the symptoms. Our patient had a likely pathogenic variant in that gene that was inherited from her mother. So at first glance, I'm thinking mom and patient are carriers for that condition. The other 2 rows are variants found in Hex A. Hex A is a recessive condition, so you need biallelic variants. She has a pathogenic variant that was inherited from her father, and then the one inherited from her mother is a variant of uncertain significance. So I just kind of redid the table. I reorganized it to put the Hex A variants together, so reorient yourselves with that. I'll talk about the KDM5B variant a little bit first. In the information given to us by the lab, they explain that biallelic pathogenic variants in KDM5B have been seen with individuals with global developmental delay and dysmorphic facial features. They also included that they have reports of de novo, so new in the patient, not inherited, single variants that seen in people with autism, non-syndromic intellectual disability, and congenital heart defects. But those variants were also found in their unaffected siblings. So whether or not this gene has some dominant effects is still debated and being researched. But put a pin in that for now. I wanted to focus on the Hex A variants. We know that they are in trans because one was inherited from mom and one was inherited from dad. And we know that when there are 2 in trans Hex A variants, that causes Tay-Sachs disease. The classic form of Tay-Sachs has onset at around 3 to 6 months with progressive weakness and loss of motor skills and other neurological findings. Those individuals have a developmental plateau and then regression around 8 to 10 months. And then a rapid decline progression of that with death occurring less than 10 years old, 5 to 7 years, most frequently reported. There are 2 other described forms of Tay-Sachs in the literature. There is a juvenile onset form of Tay-Sachs with normal development up until 2 years old, with slowing development and plateaus around 2 to 5 year range. They have an abnormal gait, dysarthria, and then by the first decade, they can develop some of those other neurological findings, including cognitive delay, with their death occurring most commonly around age 15 years old. But then there's also a third form, a late onset or sometimes called adult onset form of Tay-Sachs that can be much more variable with neurological findings and psychiatric findings. Onset for these individuals happens later in their teenage years or their young adult years. You can see slow progression over decades, including muscle weakness, dysarthria, progressive dystonia, ataxia, mild spasticity, and then psychiatric disorders like bipolar disorder or other forms of psychosis. That made us think a little bit. We know she has 2 biallelic variants in Hex A, and she is showing some of those signs that are probably more consistent with late onset Tay-Sachs. So we wanted to look further at that variant of uncertain significance in Hex A. Variants of uncertain significance are changes in genes that are different than what the lab expects to see, but they don't have enough information at the point in time to say whether or not it's pathogenic or benign. And so this is the information that they were able to give us at the time of that initial report. They said that this variant had not been observed at a significant significant frequency in the general population, had not been previously reported in infected individuals. And then the in silico analysis that they do to help predict the variant's effect on protein product of the gene suggested that it had a deleterious effect on the protein structure and function. So Dr. Griffith recommended doing enzyme activity, since we know that enzyme activity can be low or be absent with classic Tay-Sachs disease. And then in the later onset forms, there is minimal residual enzyme activity that can be found. So in that bottom right corner, I included the reference table for that enzyme activity. If she is a true carrier with that single pathogenic variant from her father, her enzyme activity would be about the 30 to 53% range. And her result is there in that dark green color, 17.4%. And from reading the report of that enzyme activity and reading notes from Dr. Griffith's discussion with that lab, the lab personnel, they believe this was consistent with late onset Tay-Sachs. So I took this to the genetic testing laboratory. I called the lab and spoke to their genetic counselor, and I said, we have more information for this patient. Would it be enough to change that uncertain classification? And with the patient and her parents' permission, I submitted that report to the lab, and it was enough to change the classification. So and that bottom bullet point in the red box there says that this variant has been identified in a patient who was referred for genetic testing at the lab, and their biochemical testing was diagnostic and consistent with the results seen in other patients with pathogenic variants in this gene. So I just wanted to highlight some of the takeaways that that I learned from this case, honestly, is that those classic pediatric conditions, sometimes they can have a non-classic presentation that in adults looks a little differently. The second point was that genetic testing is always evolving. So a reminder for myself to provide those labs with clinical evidence when I can, so that can really drive their variant interpretation and make sure that those uncertain changes can be one day reclassified appropriately. Just the impact a diagnosis may have on a family. So this patient did have a sister in her mid-20s who was, around the age that she could be starting to think about having a family, and her carrier status for Tay-Sachs may be important for her to know. That might be information that she would, use in family planning. And then just having a diagnosis opens you up to joining support groups, meeting people with the same diagnosis or a similar one to help you through your lifetime. And then how important it is for our patients to continue to follow up with us. That KDM5B variant, we haven't forgotten about it. We know that they are looking into the dominant effects of that gene. And every time she comes back, we'll review the literature and make sure, every once in a while, we're very humbled and we remember that a patient can have 2 genetic disorders going on at one time. And it's going to be important to keep up with that and make sure that we're not missing anything for her in the future.
All right, and so the case I was going to present today was a patient that we saw somewhat recently who was referred by his neurologist. This was a 34-year-old male who had a history of cerebral palsy, seizure, intellectual disability. He had reported some headaches, ptosis, and dystonia. In the referral documentation, there had been mentioned that he likely had extensive prenatal exposures to alcohol, probably other drugs and substances, and that his mom had been taking seizure medication while she was pregnant with him. He ended up being adopted at the age of 3, and his adoptive dad came with him to his visit with us. And at that time, his dad was able to give us a little bit more history and let us know that he really didn't start talking until he was about 4 years old. But since then, he had gone through special education and graduated high school with a special diploma. And when we spoke with him, the patient was working at a grocery store and was working on getting his GED. Okay, next slide. So his neurologist had ordered the testing originally and referred him with the results. So his neurologist ordered a couple gene panels for him, a dystonia gene panel, and then a gene panel looking at nuclear gene causes of mitochondrial disorders. So this is the result that he was sent in with. you can see that he has a pathogenic or positive result in a gene called SLC2A1, which is associated with glucose transporter type 1 deficiency syndrome, and certainly was the majority of what we talked about in his appointment. But you can also see there were some incidental findings on this testing as well. He had an uncertain variant in a gene called TRAP1, and this gene doesn't have any definitive phenotype associated with it at this time, but the lab had noted that they had some preliminary evidence to associate changes in this gene with intellectual disability. But given that that association isn't very strong at this point of time, and then on top of that, he had an uncertain change in the gene. So like Deanna had kind of gotten into, where we just don't know if that change is causing the gene to not work. It's not going to change his medical management at this time, though certainly we will keep an eye on it and follow up with it. And then lastly, he had a benign reportable variant in a gene called ACADS, which is associated with short-chain acyl-CoA dehydrogenase deficiency. This is more considered a biochemical phenotype than an actual metabolic condition at this point. It's just that the change he had in that gene has been previously reported as being associated with the condition, which is also recessive. So you'd need to change this anyway. So the lab will just report it for that reason. But again, the major focus in the appointment was his pathogenic change or mutation in SLC2A1. Next. So again, this gene is associated with GLUT1 deficiency. So the SLC2A1 gene encodes the GLUT1 protein, which is the major transporter of glucose across the blood-brain barrier. So before genetic testing was more readily available, individuals would get diagnosed with this condition based off their symptoms, but also based off having low glucose concentration in their cerebrospinal fluid. So luckily, we don't have to do that for this patient, as the genetic testing is enough to give him this diagnosis along with his symptoms. And then previously, we know that individuals, it used to be thought of that this was a very, typical disorder in that individuals would have very specific symptoms, but we've learned now with more genetic testing that it is a spectrum disorder. So while a majority of individuals who are diagnosed with this condition do have the classic phenotype, where they have seizures that typically begin before the age of 2 years, delayed neurological development, and then those movement disorders, along with acquired microcephaly and dysarthria, a few individuals can have this diagnosis with a more mild phenotype. So they might not have seizures, they might have more mild learning or intellectual disability, and then they can have the movement disorders as well, though they might be more episodic rather than continual. The other thing about this condition is that it is considered autosomal dominant. So having just one change or mutation in one copy of the gene is enough to have symptoms. Very rarely it's been reported in a couple of families where a child has this condition in a recessive fashion, where they themselves have the condition, but their parents carry a change in the gene and don't have symptoms themselves. But far and away, it's mostly a dominant condition. On top of that, we know about 90% of individuals who have this condition have what we call a de novo change or mutation in the gene. So they didn't inherit it from their mom or dad. This change happened for the first time in them. But we also know that about 10% of individuals with this diagnosis have a family history of the disease, though typically their parents are more minimally affected than they are. Okay, next slide. So like Deanna had mentioned many slides ago, one of the things we do in genetics as counselors is take family histories and draw out a pedigree. And certainly the history was limited for this patient because he was adopted. But what we were able to find out from the patient and his dad was that the patient's biological mother did have seizures, probably had some mild intellectual disability, and had some social challenges and had passed away from likely a drug overdose. But he did have maternal half-sisters from his mother who also had seizures and had children of their own, and probably had some similar social concerns as their mom, and that his grandmother, maternal grandmother, also had a diagnosis of epilepsy. So we went through that with him and talked about how, again, there are cases where this condition can run through a family, and the fact that his half-sisters and mom and grandma have seizures can be a little suspicious that maybe that is the case for them. Unfortunately, because of the social situation with his sisters, he had lost contact with them. But we did talk about that if they ever got back into contact, this might be an important result to share with his sisters so that they could get testing for themselves and for their children, because he did know that they had children of their own. And then for the patient himself, we talked about if he ever wanted to have children of his own, there would be that 50% chance to pass on to each pregnancy. So we had that discussion with him as well. Okay, next slide. So what we know in genetics is that we often see individuals who have neurodevelopmental spectrum disorders, so autism, intellectual disability, developmental delay. And very often, or most of the time, the genetic testing isn't going to reveal any special management for these patients. You just manage them based on symptoms. But it does give us an underlying genetic etiology for the reason why they have these symptoms. But in this particular case, there is treatment recommendations for this condition. So individuals who have GLUT1 deficiency can be placed on a ketogenic diet, and there is quite an improvement in their seizures and movement disorders if they are, adherent to that. Certainly, it's best to start this in childhood for a better outcome, but you can start anybody at any time and hope to see, again, that improvement in their movement disorders and seizures. Though, of course, a consideration for our patient, we did refer him to a dietitian, but, he's 34, he's eaten whatever he's wanted for that long, so it can be hard to stick to the keto diet. And then on top of that, if there is some intellectual disability, that could be a concern too. But I don't think he's been able to see dietetics yet, but there's hope there, and hopefully he'll get some relief for his symptoms that way. Another thing about this condition is that really the keto diet is the treatment for seizures, and they recommend that you don't use barbiturates to treat the seizures in these patients. There's some thought that that class of medication further inhibits GLUT1's ability to transport glucose. And really there's no improvement with seizures with that medication anyways. So that is an interesting case where management can be changed based on the genetic testing. And next slide. So again, really the takeaways for my case are that there are older individuals who have this neurodevelopmental spectrum disorders who maybe didn't have genetic testing in their childhood. It wasn't as readily available. And so that's certainly always a reason to refer an adult to genetics. And again, while it might not change their management in particular, it can reveal an underlying genetic etiology and therefore recurrence risk. So for their family members, like their siblings, or even for themselves. And then, of course, if you see an individual who has these delays, who had extensive prenatal exposure, it's still important to be seen by genetics because you just can't, it can be really difficult to determine to what extent the exposures contributed to their phenotype versus maybe there's an underlying genetic cause. So yes, that was my case to present. I think that's all us PEDS genetic counselors have. There's our references. And then thank you again so much for giving us this opportunity to give this talk. And with that, I will hand it over to Brittany Sears, who works with TGH Cancer Institute, and they'll go over a bit about what they do over there.
I just want to shout out a quick thank you. We are highlighting the role of the genetic counselor. We don't do any of this alone. So a quick shout out to our team to thank them for everything they do to support us. And then we'll transition. We'll let Brittany talk.
All right, thank you all. Let me get my screen shared here. Okay. And are you able to see and hear okay?
Yes.
Looks
Okay.
good.
Perfect, thank you. And I will try to be brief to be respectful of everyone's time. So in that vein, I'm going to skip a couple slides, but I'll give you some warning. So I'm coming to you from Tampa General Hospital and our Cancer Genetics Department in the Cancer Institute. We are the medical director, Dr. Rutherford, and then two genetic counselors, Allison Knoisel and myself. And then we also have a certified physician assistant, Lisa Novak, who not only does the genetic counseling piece, but also about a quarter of her workload is a cancer prevention clinic, where she'll follow any patient who has a germline predisposition to these hereditary cancer concerns and kind of coordinate their management, make sure they're getting followed up by whatever specialists and whatever screenings they need. So I thought what I'd talk to you all today is retinoblastoma, which is a really interesting malignancy because it affects people across the life course. So we typically think of this malignant tumor of the retina as an early childhood concern because it presents before the age of 5, often under the age of 3, and can even be present at birth in about half of patients who have a hereditary cause. Now, usually kids come to attention with retinoblastoma because they have leukocoria, which is kind of the opposite of that red eye response in a picture, but they might also have other kind of ocular presentations like strabismus or any sort of change in eye appearance or issues with their vision. Now, a unilateral retinoblastoma is more common than bilateral, but we also see trilateral where the pineal gland is involved. And so really there's kind of like levels of at which children can be affected with these. Now, retinoblastoma can be hereditary or sporadic. When it's hereditary, it's caused either by a mutation in the gene RB1, or it can be part of a syndromic deletion syndrome that I'm not going to really touch on today, but we do see that sometimes. Now, the likelihood of retinoblastoma being hereditary versus those sporadic causes that just happen by chance can be predicted before you do any genetic testing at all by basically an algorithm that involves family history. Is there other retinoblastoma in the family? Foci and laterality. So basically, if there is family history, this is probably hereditary. And then we are more concerned about it being hereditary if it's multifocal or in both eyes or trilaterally, like I mentioned. And so I'm going to skip through a couple of tables here that come from Gene Reviews, as the other counselors mentioned. Gene Reviews is a great resource for deep dive on the literature like this. But this is just to show you that even before doing genetic testing or talking in depth with the patient, you can predict the likelihood that a genetic mutation is present for them, given their retinoblastoma and the family history. Skip those tables. This is just an example of some unusual presentations of retinoblastoma. I'll skip, but the slides will be included that I sent to Jennifer. So with hereditary retinoblastoma, we're not only concerned about that first cancer, which is a very serious diagnosis to contend with, but also with the risk for second primary malignancies, unfortunately. So about 5% of children who have that hereditary retinoblastoma will have a second primary before the age of 10. Now, those risks are higher for children who received radiotherapy to treat their retinoblastoma. We do try to avoid radiotherapy these days now that we know more, but sometimes you have patients who were treated maybe 30, 40 years ago who did receive radiotherapy, and that's going to increase the risk for malignancy all over the body, but in particular, the central nervous system. And then for children who receive chemotherapy as part of their treatment for the retinoblastoma, we do want to follow them and just make sure there's no complications of the chemo. So not only conventional things we follow for anyone like ototoxicity, but also specifically carboplatin, we know has a small but clinically significant increased risk for myeloid leukemia in childhood. So there's still some childhood surveillance that's needed for children with a hereditary cause, an inherited cause for that retinoblastoma. We don't think there's increased risk for people who have a sporadic childhood retinoblastoma. Now, a lot of these people, unfortunately, kind of get lost to follow up in adulthood because it is predominantly a pediatric concern. But in fact, those risks for a second primary are elevated in adulthood. In particular, the melanoma and sarcoma risks are between 14 and 44%. That's a big range. We place people on the higher end of this range if they do have a family history of retinoblastoma. If they're the first person in their family to be affected, which is not an uncommon finding, we think they're on the lower end, often because they are mosaic or it's not present in every cell of their body. We also see with hereditary retinoblastoma and these RB1 mutations that there's an increased risk for female breast cancer. Right now, we don't have specific screening recommendations to monitor for that, like we would for a BRCA mutation, for example. But I think right now the recommendations are to tackle that based on the family history and kind of the clinical presentation and the level of anxiety in the patient for those concerns. So I want to talk to you about my retinoblastoma case who I saw recently. This is a 56-year-old female. She actually came to our attention in genetics from her medical oncologist who had met with her to talk about a recent diagnosis of a leiomyosarcoma in her left calf. So back in 2020, she noticed a bump developing or mass inside of her calf. She had this worked up It got an MRI, was biopsied, and reportedly benign. We never did get our hands on a pathology report, but patient report is benign. And then in about 2 years later, last summer, she noticed that there was a rapid increase in size and numbness, and she presented to her dermatologist where she lived locally on the East Coast, who did an excision in the office of this large 6-centimeter mass, sent it to pathology, which demonstrated the leiomyosarcoma and unfortunately had positive margins. So she came to TGH for her medical and surgical management. She ended up undergoing radical resection with brachytherapy and reconstruction because that mass was so large. And so when I met with her, I knew about this leiomyosarcoma, but it turns out she also had a childhood history of retinoblastoma. And so we met and discussed her family history. And what she told me was that not only did she have retinoblastoma herself at the age of 2, which was diagnosed where she lived in Trinidad and Tobago, but both of her daughters also had retinoblastoma. And so as we're doing the intake and collection, I asked her, did anyone ever talk to you about the chance of this being hereditary? And she said, no one ever told me as a child or as an adult when I was pregnant. It only came up when we found it in my first daughter, who was diagnosed around the age of 1. She said, and then I was aware it was genetic. We knew to screen my second daughter from birth. And in fact, we found retinoblastoma for her as soon as she was born. So it was really unfortunate that she didn't get any genetic counseling, not only for issues of recurrence risk, but she didn't get any surveillance in adulthood to have a really low threshold of suspicion for that mass that was developing. So this was, a series of nets, unfortunately, that she missed that I think, would have been the best possible care for her. So this highlights a couple of layers of the benefits of genetic counseling. So first of all, at diagnosis, you have a child with retinoblastoma. It can inform their diagnosis and their treatment because, of course, we want to avoid radiation or DNA damaging agents in someone who's prone to hereditary cancers. And then it could also have told her parents recurrence risks for siblings. Now, fortunately, her brother is unaffected. She is presumably the first person in the family affected. She said no one is really interested in testing in her generation and above, though. And then we have some anticipatory guidance for the affected patient. So for the family at that point, what are we looking for or looking at in the future for childhood surveillance and then adulthood? So the childhood surveillance would be basically checkups with oncology, having a low threshold for suspicion for a second malignancy, minimizing that radiation exposure, other DNA damaging agents like exposure to excess UV or cigarette smoke, and then some age-appropriate discussion as the child ages about recurrence risks for their future children, if they think about having any. And then in adulthood, of course, continue screening for those second primary malignancies. We know those breast cancer risks are increased, as are melanoma and sarcoma. So people should at the very least, be receiving a full body skin exam every year for those melanoma risks. And then in adulthood, being aware of the recurrence risks to children, so they have opportunities to make decisions about family planning, some of the assisted reproductive techniques that we've touched on already, like PGD, pre-implantation diagnosis after IVF, prenatal testing once a person is pregnant, and there are actually implications for delivery of an affected pregnancy because so many of them do already have a retinoblastoma at birth. So this is a great example of a condition that has a high chance to be hereditary at face value. And then you can see layers and layers and layers of possible benefits once genetic counseling gets involved here. So that is all I had for this retinoblastoma patient. I think it highlighted some of the benefits of genetic counseling in hereditary cancer. With that, I think I will stop and then I'll take any questions that y'all had for any of us, really.
Go ahead and take the mic if you have any questions.
I don't have a particular question, but I'm one of the primary care providers at USF, and I just wanted to say thank you. This was an incredibly informative talk, and definitely an area that I had a lot of holes in my knowledge. So thanks for putting this together.
You're welcome. It's nice to talk to everyone. I will add a sort of a riff of my own on the pediatric presentation about neurofibromatosis type 1. We actually see adults, we have a lot of overlap between our practices. So I had an adult with NF1 recently, and he had a clinical diagnosis, but was interested in having a family someday, and having biological children. And so he wanted to know, have an identifiable mutation so that future pregnancies could be tested. And so that was the reason we actually did testing for this gentleman. We, knowing the very sophisticated, complicated chemistry behind genetic testing, we ordered testing with RNA analyses for him. And good thing we did, because they would not, it turns out, have detected his NF1 mutation without doing that extra layer in the laboratory. So that was a huge benefit of having someone who really knew what kind of testing was available to order for him. And then he also, I would have said, at face value, that he was profoundly affected. He had a plexiform neurofibroma that caused lots and lots of pain. He is being seen by MedOnc for this. But when I talked to him about being, more seriously affected, he was like, "Oh, I'm mildly affected. People in my family are in wheelchairs." And so that just goes to show you how important it is to assess a person's perception of their condition, because he was pretty low key about it, to be honest.